I'm Joe Gentile. I'm at part of SciMed here in town. It's a big multi-specialty group. We have all different types of doctors. I'm one of the orthopedic surgeons of the group. So just a little bit about myself first. I grew up in Ann Arbor, Michigan. Went to Johns Hopkins for college, Vanderbilt for medical school, and then came here to Gainesville for all my surgical training, where I finished a couple years ago. So now I'm part of, again, SciMed here in town. I primarily work out of North Florida Hospital here in town. That's where I do all my surgeries. This is my family. It's my wife, Lori. She's a general surgeon at the University of Florida. My son, Jack, and my daughter, Paige. So today we're going to primarily talk about arthritis and joint pain, mainly of the shoulder, hip, and knee. Although we have some time for questions at the end, I'd be happy to answer any questions about pretty much anything you have. Talk about conservative options first for these, and then certainly talk about surgery, in particular joint replacement, kind of what to expect kind of before, during, and after these surgeries. So arthritis is one of the, probably the top cause of joint pain in this country. About 50 million people in the U.S. have some type of form of arthritis. Numbers are just rising by the day, and about 1 million new people every year start to experience symptoms from their arthritis. So while certainly pain can be an issue, the bigger issue a lot of times is frankly losing function, losing mobility, losing your independence because of your arthritis. So when moving becomes a problem, you can't do normal activities. So when you think about trying to seek relief for your problems. So getting into the different joints, the knee joint really is like a hinge. It's a bit more complex than that, but like other hinges, it should ideally you'll be able to glide freely without much motion or friction. Here's a healthy knee. So you have cartilage in your knees. You can see there's the bones here, and that space between them is the cartilage. That's the cushion. It helps keep the joint lubricated and cushioned while it moves. So the knee is actually, it doesn't just hinge, it also slightly glides and twists as well. Just the basic anatomy, so you have all the ligaments on the inside and outside, then you have the femur, which is the thigh bone, the tibia, which is the shin bone, and the patella, which is the kneecap. You have the cartilage on each side, and you have these little C-shaped extra shock absorbers inside the knee, which are called the meniscus. This is a knee with arthritis. You can see the difference. How on the inside here, there's no more of that cushion. It's bone rubbing against bone. You can see here, the cartilage is worn away, the meniscus have ground down. So when you don't have that normal shock absorber, that normal cushion, that creates friction, which creates pain. See some more examples here of you can have it underneath the kneecap, and certainly in different parts of the knee, but certainly you can have it throughout the entire knee. So unfortunately, unlike other parts of your body which can regenerate, cartilage does not regrow. The analogy I like to use is your cartilage is like tread on a tire. Once you wear down that tread, it's not coming back. Moving on to the hip. The hip is much more like a ball and socket. And unfortunately, when you get arthritis, it's similar to having corrosion in a ball and socket joint where it can't move as well as it should. See a healthy hip here. So when this is healthy, you should be able to walk and do all your activities without pain. However, when you wear away the cartilage in the knee and get arthritis, you can get bone rubbing against bone, which again creates friction, which creates pain. You can see the difference here between a healthy hip. You have the nice ball here, the nice socket, plenty of space there in between the two. And here you can see how that is worn away, and you've actually starting to wear into the bone when the cartilage wears away. So the third one is the shoulder. So the shoulder is also similar to ball and socket joint. It has the most range of motion of any joint in your body. And it looks much more like a golf tee and a golf ball. So similar to the hip, when you get corrosion in a joint, it'll stop working. You can see a healthy shoulder here. You have certainly the ball and the socket, but you have multiple layers of tissue on top of the ball and socket itself. That help keep the shoulder together, help keep it moving. You can see arthritic joint here. Similar to other joints, the cartilage will wear out. You'll get wear and tear, and bone rubbing against bone, which again creates friction, creates pain. It's a fairly similar theme here. So there's kind of two major types of arthritis. There's primary arthritis in a slightly younger population. This is more the simple wear and tear. something called rotator cuff tear arthropathy. This is something you get typically people who are older and they have a lot of problems with their rotator cuff and can lead to arthritis that way. And these are different processes and they have different treatments. So with primary arthritis of the shoulder, it's just a simple wear and tear. When the cartilage wears off and you're bone rubbing against bone, typically all the tendons, ligaments, all those are still intact and still working. You can see here a normal shoulder, the nice ball, the nice socket, plenty of space in between those. You can see with arthritis here how the ball is starting to wear away. There's no more space between the ball and the socket. Rotator cuff tear arthropathy, this is typically seen in people who have large rotator cuff tears that are too big or have been there too long to actually repair. And what happens is the rotator cuff normally it sits around the ball and keeps the ball centered in the socket when you're moving the shoulder. And what happens is when that's not there, your large shoulder muscle, the deltoid muscle, will actually pull the ball up and out of the socket here. And it actually will get wear against the top part of the socket and the shoulder blade here. Here's what happens on x-ray. Again, you can see the normal ball sitting nicely in the middle of the socket. And then here what happens, you can see how that ball has been pulled up out of the socket. It's worn away the top part of the socket and actually the shoulder blade here. Different treatment options. Certainly making different types of lifestyle changes, especially if you have problems with hip or knee arthritis. Losing weight can make a huge difference, simply just putting less stress on those joints. But also different things like flexibility exercises, low impact activities can also give you some relief and give you much more function. Certainly physical therapy also can be extremely helpful for any joints. Strengthen the muscles around the joints, give you more motion, more flexibility. So very commonly this will be prescribed for many joint problems. Certainly a cane or a walker can be pretty helpful. Sometimes certain types of braces can be helpful, in particular for the knee. Different types of medications, in particular anti-inflammatory medications, such as Advil, Aleve. Also different topical medicines can be helpful. Tylenol, a medicine called tramadol, and certainly glucosamine chondroitin can certainly be helpful for joint problems. However, some of these medications, especially if you're on other medications, can have side effects, so certainly it's good to coordinate this with your primary doctor and make sure there are no interactions with other medications you're taking. Certainly injections in any joints can also be helpful. A lot of times these can be done in the clinic setting, but some of them are actually better done using either like an x-ray and ultrasound to help guide them into some of the deeper joints. The hip in particular is pretty deep joint. That's usually best done under x-ray, where you can actually see the needle go into the joint and make sure the medicine is actually going in where it's supposed to. Knee injections, these can usually pretty easily be done in the clinic. Very commonly you get the cortisone type injections. These are anti-inflammation medications directly in the knee. Some doctors use what's called viscosupplementation, which is the joint lubrication. Those are much less and less commonly being used as more studies are coming out showing that those actually don't really make much of a difference. There's something called platelet-rich plasma, which is fairly new, where they actually take some of your blood, kind of spin it down to get all the platelets in, and actually inject it back into the knee. And there's some studies that show that might actually be helpful with inflammation. For the shoulder, there's something called a subacromial injection. So this is in the area above the rotator cuff, above the ball and socket, where you commonly can have some inflammation. So this is done again more for rotator cuff issues as opposed to necessarily arthritis. And certainly you can do injections into the ball and socket. I actually prefer to have this done by some of the doctors in my practice who will use an x-ray. It's a deeper joint and it's just much more accurate when you actually have an x-ray help guiding the needle in to the joint. Sometimes for arthritis, you can go in there and stick the instruments in there and try and clean things up. But a lot of times when things are as advanced as this, when you're bone rubbing against bone, there's really not much in there to clean out. This is a pretty ineffective surgery. When it gets to this point, you're really thinking about needing to do something more like a replacement. So again, when all these things these conservative treatments aren't giving you any relief, that's when you think about some type of joint replacement surgery. Just to give you some perspective, there's about 700,000 knee replacements performed in this country a year, about 300,000 knee hip replacements, about 50,000 shoulder replacements. We've actually done some projections, and especially over the next 20 years, knee replacements are expected to, the need for them is expected to skyrocket in this country. And unfortunately, the number of surgeons who are doing them is going down, so there may be in the future a bit of a supply and demand issue, unfortunately. So typically, either your family doctor or it can even be another type of specialty doctor can refer you to an orthopedic doctor's office. Typically, you would talk about your joint, the issues you've been having, do a physical exam, get x-rays if they haven't already been done, and then try some of these non-operative treatments if they haven't been done by other doctors. And certainly for follow-up visits, you either adjust, add, modify anything that's been done before. And once these things have all been exhausted and nothing else is working, that's when you think about surgery. So to be really eligible for this, you really have to have severe arthritis, have failed all these non-operative things, have fairly disabling pain, and then certainly not have any other major medical issues that would make a big surgery unsafe to have. So typically, once you sign up for surgery, we'll actually send you back to your primary doctor and any other specialty doctor, you have a cardiologist or any other doctors, to make sure you're as healthy as possible, get any tests you would need, any blood tests, chest x-ray, make sure you're as medically healthy as possible prior to surgery. So day of surgery, you'll show up, go to the registration office, and get brought up to a preoperative area. We'll get changed into a gown, get an IV placed, talk with all the nursing, the anesthesia doctor, and they'll talk to you more about the anesthesia and what they'll be doing for you to put you to sleep. And one thing that's become much more common in the last 5 to 10 years is something called multimodal pain management. And what this is trying to give you different types of pain medicine both before, during, and after surgery to help, one, minimize pain, and two, minimize the amount of narcotics that you have to take, because those have a lot of potential side effects and a lot of issues. So usually before the surgery, we'll give you like a full dose of Tylenol, either a medicine called Lyrica or Neurontin, which is a nerve-type medicine, and then some type of real potent anti-inflammatory to kind of prime your system. And during the surgery, typically the anesthesia doctors do some type of nerve block, either in your neck for your shoulder or in your upper leg for your knee, to help keep the leg numb both during and after the surgery. Then during the surgery, you'll inject medicine around the area where we're doing the surgery, both anti-inflammation medicine and numbing medicine to help with pain during and after the surgery. And afterwards, we'll give you these similar medicines to before, in addition to the narcotic pain medicine to help with your pain. So in the last, again, 5 to 10 years, we've made a lot of, I would say, definite breakthroughs in terms of getting pain under better control and minimizing a lot of the side effects of these medicines. So before the surgery, your surgeon will come by answering last-second questions. We'll mark the side you're having the surgery, and you head back to the operating room where you had the surgery performed. So usually before they put you to sleep to do the nerve block, depending on what surgery you have, that's done by the anesthesia doctor. And the surgeon and our team will wash our hands. We give you antibiotics before the surgery, after the surgery. We actually wear these, that is actually what we wear, they look like spacesuits we wear during the surgery. Take every possible precaution to help prevent any type of infection from setting in for your drug replacement. So getting into the more specifics, I'll start with the knee. So typically you go through the front of the knee, and depending on what you have done or if you have previous surgeries, you either go straight from the front of the knee, or if you have previous scars, we'll try and incorporate some of those scars. And sometimes if you're doing, for example, a partial replacement, sometimes you can sheet that to one side or the other depending on what part of the knee you're replacing. So again, depending on what kind of arthritis you have and where it's located, if it's only in part of the knee, then you can have the option of potentially just replacing part of the knee. However, if the arthritis is through the entire knee, you need to replace the entire knee and do a total replacement. So the partial replacement, again, the knee is kind of broken down into three main areas. There's the outside part of the knee, the inside part of the knee, and then underneath the kneecap. And if the arthritis is only in a certain part of the knee, you don't have to replace the whole knee. The analogy I like to use is if you have a bad spark plug, you're not going to replace your entire car engine. You're just going to replace the spark plug. So I think it makes sense in the knee as well. So again, we have the option now of doing just the outside part of the knee, just the inside part of the knee, or just underneath the kneecap, or any combination of those. Again, like I said, if you have arthritis on the inside and the kneecap, you can just do it in just part of the knee. What the big advantage of this is, it's a smaller surgery. You leave a lot more of your normal ligaments. Most people tend to recover more quicker, and feel like their knee feels more natural to them. That being said, if you have arthritis throughout the entire knee, or some of your ligaments aren't functioning when we get in there, doing the partial knee would be the wrong thing to do. If you have arthritis throughout the entire knee, you need to go ahead and replace the whole knee. So what we actually do is we actually cut off the arthritis. We actually use power saws to cut the bone, actually cut off the ends of the bone, replace them with metal caps, then actually plastic pieces that go in between the two metal caps. Put a cap on the thigh bone here, cap on the shin bone here. Then we actually put a plastic piece on the under part of the kneecap. So we're basically cutting off all the arthritis in the knee, replacing it with metal and plastic. So we actually have, there's fairly exciting technology that's coming out fairly recently. One of that's is computer navigation, where we can actually use a computer system to help guide us to make our cuts and make them with more precision and accuracy. So what we can do is actually put this kind of right next to our operating table. What we do is we'll put trackers on the bone, and we can actually record the locations of the bone and actually where it is in space. And what that does is the computer will actually generate these 3D models. What that does is it'll help us measure the bones for correct sizes and also the correct measurements. This allows us to actually much more precisely, as opposed to some of the handheld things that traditionally have been used, to much more accurately put the rotation of where everything needs to be. Just make sure it's going to be done more precisely and actually give you a ideally better outcome in the end. Showing what this can do is, again, just make us more precise and put things in more accurately, which ideally in the long run will make things last longer. Additionally, we have the option of robotic assistance. So actually this can be done for partial knee, hip, and potentially knee replacements in the future. What we actually do is we actually have a robot arm, and what this does is actually, we actually watch the screen here, we actually take off a very precise, so instead of using a saw, we're actually using a burr, which allows us to be very precise in terms of what we're actually removing. I think this is pretty exciting technology, and just, again, the surgeon is still doing the surgery. It's just a tool that is making us more accurate at what we're doing. It makes it much more reproducible in my mind. So getting into hips, so what you actually do, we put in a new socket and a new ball, and what do you do is you actually will place a metal socket, and you have a plastic liner inside that metal socket. Then actually you have a stem that goes into the femur bone here, and then actually a ball. That is what creates your new joint. And there's different combinations of this liner and ball. And what they do over time certainly is they can wear out. And what you have in there can sometimes determine how long they're going to last. So there's been different combinations over many years. In terms of the liner, you can have polyethylene, which is basically a high-grade plastic. You can have ceramic or metal. And then for the head, you can have either ceramic or metal. I'm sure you guys have all heard of the issues with the metal and metal heads and metal sockets. And those are no longer used anymore. There's a lot of big issues with people having reactions to those. So I would say if there's a gold standard right now, what I would have done in my 30s to hopefully last me 50 years would be a plastic liner and a ceramic ball. But certainly there are other ones that, a metal head is completely fine. It works pretty well. There's not a huge difference in terms of between the ceramic and metal heads. It's certainly something to think about and discuss. So I think that the main thing with hips is, unlike the knee where you pretty much have to go from the front, all doctors do it the same. With the hip, there are different ways of doing the same surgery. We're still putting in the same socket and ball, but there's different ways of kind of getting there. The posterior approach is probably the most common. There are different ways: lateral approach, anterolateral approach, and there's something called the anterior approach. It just depends on your surgeon and kind of the way they like to do it. There are advantages and disadvantages of them all. The posterior approach, I think a big disadvantage is that actually you have to split through your big butt muscle here, the gluteus maximus. You actually have to cut off muscle from the femur bone to actually get into the hip. With this way, there unfortunately is a higher chance of the hip actually popping out of sockets. And a lot of times in order to get it in tight enough so it won't pop out, you actually have to make either the hip wider or the leg longer, which can, again, be a big issue for people. And after the surgery, until things kind of heal down, there's a lot of more restrictions. You can't lift your leg up, you can't cross it over, things like that, to minimize the risk of it popping out. What I like to use is actually the anterior approach. And what this does is actually you go between muscles, and because of this, you're not actually cutting muscles and less chance of the hip popping out of sockets. We actually use an x-ray during the surgery to actually double check everything and make sure that our legs, the hips aren't too wide, the legs aren't too long. And most people definitely in the first 6 weeks compared to the other ways of doing the surgery, much less pain, a lot quicker to return to their normal activities. So like I said, you actually go between muscles, and actually because you're coming from the front, it's actually, the hip joint is actually a lot closer to the front of the leg than the back of the leg, so it's actually a lot easier to get to. So we go between muscles without having to cut any muscles off the hip, which again leads to a lot less pain, a lot quicker recovery for you after the surgery. A big part of this is those gluteal muscles, those butt muscles, which are probably the most important muscles for your function after the surgery, are undisturbed. So it really leads to less recovery and less therapy after the surgery. So you really have minimal restrictions after doing the anterior approach. You can get up, bend your hip. You don't have to worry about bending it up or getting down on a low toilet, things like that. You can bear weight on it as soon as you feel comfortable. We do use actually a special table that actually helps us do this surgery. You ask, well, if this is so good, why don't all surgeons do it? And it's a big debate. Some people think it's not as good as other people say it is, and certainly a lot of it is if you're not trained to do it this way, it can be pretty difficult to try and do it. So certainly some people, they've been trained the traditional way. They don't want to necessarily learn some new way. So, but certainly, how can you request it? I mean, again, it's if you're doing a surgeon who's all they do is different ways. I mean, I wouldn't request them to do something they don't do a lot because that's could lead to some issues. But certainly, there are a lot of doctors. There's different ways of doing it, and in the end, you're going to have your joint replaced. You're going to do well either way. But so getting into the shoulder, it's typically done through an incision in the front of the shoulder. What you actually do is you, similar to other joints, you cut off where the arthritis is and replace it with metal and plastic. So a new metal ball, plastic liner. Again, primary arthritis, this is simple wear and tear where the cartilage is worn off and you have bone rubbing against bone. And typically, again, the rotator cuff with primary arthritis is still intact, it's still working well. You don't have to substitute for that. So what you do is, the glenoid, which is the socket, new plastic liner, you put a stem into the arm bone, and then a new metal head here. And what's nice with the modern technology we have is we don't have it's not just one size fits all. We have many sizes. We have, if you're 4 foot or 8 foot tall, we have something that will fit you. And we can really customize this to essentially exactly replicate what you had before and match your normal anatomy. This is what it looks like before. You can see the ball completely worn away, no cartilage. Then we've replaced that. You can't see the plastic here, but there's the plastic liner. Then you have the new metal head. So something called a reverse shoulder replacement. So this is done for that people who have the irreparable rotator cuff tears and they have the rotator cuff tear arthropathy. Again, the rotator cuff isn't there and the ball is being pulled out of the socket here. Again, this is what this looks like. So in this case, when you don't have the normal rotator cuff, you can't just replace the ball and socket because the rotator cuff isn't there. And if you put what you put in with this the new ball and socket, it's still going to be pulled out. So you have to actually not only replace the joint, you also have to replace the function of the rotator cuff. And the way you do that is actually putting the ball where the socket is here, and the socket where the ball used to be. What that does is actually pulls the arm down, and actually your big shoulder muscle here, the deltoid, it actually puts that under some tension and allows that to be the function of the rotator cuff. So your ball actually, so it won't be pulled up and out of the socket. You can see how the ball is way up here into the shoulder blade. You can see how it's been pulled down here. You put this arm muscle, your deltoid muscle, under tension. It allows you to have function of the arm. So after surgery, whether it's a hip, knee, or shoulder, you go to a recovery room. The doctor will go talk to your family, let them know how everything went. You start eating and drinking right away. You have pain medicines as needed. Typically, therapists will come start working with you right away. Usually with hip or knee, we'll try and get you up same day of surgery if it's been in the morning. And start just some gentle exercises for whatever joint you had worked on. Typically, a social worker will talk to you about plans for afterwards. So day 1 or 2, usually if you have a hip or knee replacement, you usually have a catheter in your bladder. We try and get that out right away. Usually you switch to oral pain medications. And definitely with shoulder replacements, you always pretty much leave the next day. With hips or knees, they're either anywhere from 1 to 2 or 3 days, depending how quickly you're moving around. And depending what your home situation is, if you have family at home, pretty much you can almost always go home. We send therapists and nurse out to you. But if you, for example, live alone, don't have a lot of support, typically it's best to go to a rehab center afterwards. And again, this is based on your family support, how independent you are. Because the last thing you want to do is send you home and have it not be safe for you, not be able to get around and do things like go to the bathroom and get up and eat. So for the shoulder, you can move your arm, your hand and elbow immediately. You have a sling for about 3 to 4 weeks. You start range of motion in the first 6 weeks, and initially it's the therapist moving your arm, then eventually it's you moving your arm. Usually by about 6 weeks have light use and strengthening exercises. For hip, usually you're full weight bearing. The anterior approach, you have, again, minimal precautions. If you do it from the posterior approach, you usually can't flex up your hip, can't bring it across, and you can't turn the leg in. Usually you start with a walker, progress to a cane, and then some people are walking only about 2 weeks. Flexibility, strengthening, gait exercises. The main thing is just kind of getting back to your normal activities, your normal walking. Again, with the knee, usually full weight bearing. Knees tend to be a lot more therapy compared to the hips by far. The first 6 weeks, you're really trying to focus on getting your range of motion back. Then after about 6 weeks, you move into more strengthening while continuing to work on the range of motion. So for the shoulder, about 3 months, most people feel pretty good. They usually have a little bit of weakness left. 6 months, usually pretty much pain-free, usually about 2/3 of your motion. And by about a year, most people are pretty much pain-free, and you really have minimal limitations depending on which procedure you had done. For the hip, again, depending on which way you had the surgery done, it's usually the first 6 weeks where you notice the biggest difference. Again, I've had people walk into my clinic at their 2-week post-op appointment, and you couldn't even tell they had surgery done. And some people certainly take longer. They may need a walker for a little bit longer. Everyone's different. Usually by about 6 weeks, you're usually walking fairly normally. By 3 months, usually pretty much close to full function. But again, there's always a spectrum of how people do and how they recover. For the knee, knee is different. Typically, there's a lot more pain with knee replacements, even with all the medicines we give you. Therapy can be pretty hard. However, usually by about 6 weeks, you're usually feeling either as good or better than you did before the surgery. And then over the subsequent year, you continue to get improvements and more strength, more motion, and start to feel better and better. So unfortunately, with any type of surgery, there's always risks of different complications. The things we put in, if you have them in for many, many years, especially if you're young, they can become loose. The thing we worry about the most probably is infection. And again, like I said, we take all possible precautions to prevent this, but sometimes you can be doing just fine for 10, 15 years. You can have some bug floating around your body. It can get infected. Can go to your joint. So sometimes that can happen, and that's a pretty big deal. These certainly can wear out. In particular, when you have a hip or knee replaced, you can be more prone to blood clots in your legs. And we'll typically give you blood thinners for a couple weeks to help prevent this. Again, this is more an issue with the hip or the shoulder, but they can actually pop out of sockets if they're not put in properly or if you go into an improper position. You can have some nerve injuries or pain. or potentially in the future, if things are popping out or have worn out, you may need to have further surgery. So the thing I always like to discuss with patients beforehand is what their expectations are, and making sure that these are realistic. And when you have arthritis, the joint replacement is most reliable at reducing your pain from the arthritis. If I replace your shoulder, it's not going to be the shoulder you had when you were 15 years old. That's just not reasonable. We don't, maybe in 100 years we can do that, but the technology we have now, it's mainly reducing your pain, and then depending on what other damage you have in the shoulder, certainly you can rehab it and get a lot of function, but the main thing you're going to get is the pain relief. Just a few questions. Will you be able to go through a metal detector? Yes. You're going to probably set it off, but half the people in this country probably have some metal at some point in their body, so it's not uncommon. Can you have an MRI? Yes. Metal's not going to be ripped out of your body. All the metal that's been put in people for probably the last 40 years is MRI compatible, meaning it's it's not going to be pulled out of your body.
It's not.
So when can you drive? Usually about 2 to 6 weeks, depending on what you had done and which side was done. Certainly if you had like your left hip or left knee replaced, usually about 2 weeks, you should be able to, as long as you're off pain medicine. Certainly if it's your right side, it's going to depend on how quickly you're moving around and how well that leg is moving. In terms of sport participation, for hip or knee, obviously we probably want you off any assistive devices. Swimming, you can usually get in a pool after about 2 to 3 weeks, once your incision is completely healed up. Tennis, usually by about 6 weeks. For golf, you can be chipping and putting right away, and then usually full swings by about 6 weeks. For the shoulder, about 85% of people can get back to previous levels, and it's really your motivation that's kind of the biggest thing. Usually by about 3 months, and usually full activity by about 6. Reverse replacement, you have more restrictions than the regular shoulder replacement. That's because you don't have a lot of the normal muscles that are usually there. There's a lot more stress put on that implant, so we don't want to do too much that you would actually get it to become loose. We usually do golf or swimming or aerobics. Tennis, skiing, or rollerblading if you've done these things before, but things like weightlifting and water skiing are usually frowned upon. In terms of golf, usually about 4 to 6 weeks, which gives you time to work on your short game. There's really no restriction on the amount played. Actually, there was one study that showed a 5-stroke improvement after the shoulder had been done. I was actually at a Rotary Club meeting, I think it was last year, and a guy asked me, he said, so if I get both shoulders replaced, does that mean I get a 10-stroke improvement? All right. Thank you very much.